their cameras. Sorry, that's just the recording starting. If everyone else could turn off their cameras and to make sure they stay on mute, that just helps with the stream for particularly people where internet isn't the strongest around the state. And I'll hand it over to you, Alana.
Great, thank you for that very kind introduction. I'll just get my PowerPoint up and running. Okay, great. So good morning, everyone. My name is Alana and I'm presenting on behalf of the WA Cervical Cancer Prevention Program, or otherwise known as WACCPP, to provide an update on the National Cervical Screening Program. For those that aren't aware, the WACCPP sits within the North Metropolitan Health Service and was established in 1992 as a state component of the National Cervical Screening Program. The program is committed to reducing cervical cancer cases and deaths by maximising screening participation among eligible WA women and people with a cervix. We are a statewide program and we provide leadership to health professionals and the community to support implementation of the National Cervical Screening Program within WA. Before I go any further, I would like to acknowledge the Noongar people as the traditional owners and custodians of the land on which we work and pay respect to their elders, both past, present and emerging. The WA Cervical Cancer Prevention Program recognises, respects and values the Aboriginal culture as we walk a new path together. Today, the key updates I'll be covering include providing a brief overview of the National HPV Vaccination Program, the National Cervical Screening Program, and an update on the National Cervical Cancer Elimination Strategy, along with discussing the expansion of self-collection within cervical screening. In terms of preventing cervical cancer in Australia, we do have a two-pillar approach. So the National Human Papillomavirus or HPV vaccination program, and the second being routine population screening through the National Cervical Screening Program, which I'll cover in more detail shortly. The HPV vaccine protects against some types of cancer-causing HPV, including oncogenic types 16 and 18, which account for around 70% of cervical cancers. Since the HPV vaccine does not protect against all types of HPV known to cause cervical cancer, HPV vaccinated women still need to have regular cervical screening. From 2018, Gardasil 9 vaccination has been administered in 2 or 3 doses to all school-age students between the ages of 11 to 13, so usually around year 8, to all genders as part of a herd immunity approach. By administering the vaccination to this age group, ideally immunity is developed prior to any first sexual contact or exposure. In terms of HPV coverage, in 2020, 79% of all girls and 78% of all boys in WA had completed the HPV vaccine schedule by age 15, which was relatively on par with the national figures. Looking at vaccine coverage amongst Aboriginal and Torres Strait Islander adolescents in WA, the uptake was lower at 65% for girls and 60% for boys. So taking a look at the National Cervical Screening Program, as most would know, on the 1st of December 2017, there were significant changes to Australia's cervical screening policy and practice, otherwise known as the renewal. These changes included shifting from a 2-yearly pap smear to a 5-yearly cervical screening test, which includes an HPV test with reflex liquid-based cytology where it's indicated. The screening age range also increased from women aged 18 to 69 years to women aged 25 to 74 years. With the renewal, we've also moved to a risk-based approach for screening, where women receive a result based on their risk of developing significant cervical abnormalities within the next 5 years. These changes were based on extensive evidence, demonstrating that HPV is a more sensitive screening test and providing better protection against cervical cancer through detection of HPV before cell changes can occur. The renewal also brought the introduction of a new self-collection option for screening, which I'll cover in more detail shortly. As you can see, the changes are summarised simply on this slide, but in essence, our methods for screening have become more accurate, therefore it's needed less often. So this graph presents the latest participation data currently available for WA. It's important to note that participation in the new 5-year program cannot be properly reported until there are 5 years of data which are available. In the meantime, this 3-year preliminary estimate for the 2018 to 21 period has been calculated. As you can see, people aged 25 to 29 years had the highest participation rate at around 73.9%. People aged 70 to 74 had the lowest participation rate at 31.1%. Although lower participation rates are expected amongst this age group as they've re-entered the program, as they would have exited the program previously at age 69. Overall, the participation rate for all women aged 25 to 74 years in WA was 64.4%, which tells us that nearly half of all eligible women in WA are under-screened or have never screened. This shows us that there's still a lot of work to be done in improving the screening uptake. I'll now provide a brief update on the National Cervical Cancer Elimination Strategy. If we look at the global effort to eliminate cervical cancer, you may be aware that in November 2020, the World Health Organization officially launched the global strategy to accelerate the elimination of cervical cancer as a public health problem, which is when each country around the world has less than 4 cases of cervical cancer diagnosed for every 100,000 women in their population. In response to the global strategy, in November 2021, the Australian government announced the development of a collaborative national cervical cancer elimination strategy. The project is being led by the Australian Centre for Prevention of Cervical Cancer and will inform the Australian Government Department of Health's future activities to eliminate cervical cancer as a public health problem in Australia by 2035. In developing the strategy, the aim will be to better understand what it takes to ensure equitable access across Australia to HPV vaccination, cervical screening, and high-quality patient-centred care for those diagnosed with cervical cancer or pre-cancer changes. Australia is on track to be one of the first countries in the world to eliminate cervical cancer. However, this can only be achieved if no one is left behind. Unfortunately, cervical cancer is a disease of inequity, and we know that there is a higher incidence in certain groups. In fact, more than 70% of women who develop cervical cancer in Australia are either never screened or do not screen regularly. Typically, there is lower engagement in screening related to socioeconomic disadvantage, geographical remoteness, I should say, those living with a disability, those from culturally and linguistically diverse backgrounds, Aboriginal and Torres Strait Islander women, and those who've experienced sexual assault. As part of the World Health Organization global strategy, there is a target to reach 90% engagement in screening. But as we saw on a previous slide, within WA, our current engagement is sitting just above 64%, highlighting there is still a lot of work to be done in this space. So if you'd like to get involved, you can register your interest to receive project updates and visit the project website for more information. I'm now going to talk a little bit about self-collection. So as I mentioned earlier, a self-collection option was introduced as part of the National Cervical Screening Program renewal, allowing eligible participants to collect their own vaginal swab for HPV testing. From 2017 until July this year, self-collection was only available for asymptomatic women aged between 30 years or over who had never screened or were overdue for screening by 2 years or more. However, from the 1st of July this year, self-collection has become available for all who are eligible to screen and is no longer restricted to under-screened or never screened women. This decision was made following a review of available evidence showing that self-collected samples are a safe, effective excuse me, and as accurate as clinician-collected tests in detecting HPV. This change means that self-collection is now available to all women and people with a cervix under the NCSP, giving women a choice in screening method, either self-collected or clinician-collected, access through a healthcare provider in both cases. Healthcare providers such as GPs and nurses continue to play a critical role in supporting patients with cervical screening, as self-collection must be facilitated and requested by a healthcare provider who also routinely offers cervical screening. As self-collected samples are from the vagina, sorry, I've just jumped ahead there, we'll just continue on. As self-collected samples are from the vagina and not the cervix, it can only be tested for HPV and not for cervical cell abnormalities. It is therefore important to ensure that the patient understands that if a self-collected sample returns a positive HPV result, they will need to return to their healthcare provider for a cervical sample to be collected by a practitioner or be referred to a specialist for colposcopy. As mentioned earlier, more than 70% of women diagnosed with invasive cervical cancer are under-screened or are never screened. By giving women the choice to collect their own sample, we are removing a significant barrier to participate in screening, which will hopefully result in an increase in screening participation. So what can you do to support these changes? So you can read the latest National Cervical Screening Program update on self-collection expansion, and you'll get a copy of all of these slides after the presentation, so you can follow these links. You can review the updated NCSP clinical guidelines. You can visit the King Edward Memorial Health website, Memorial Hospital website, which continues to be updated with the latest information. You can visit www.health.gov.au/NCSP. You can read Cancer Council's self-collection FAQs for providers, and you can also subscribe to the WACCPP's Cervical Insight newsletter at the following email address. In terms of resources, you can see some great options on the screen here. The national program resources include fact sheets, quick reference guides, etc. And education modules are also being reviewed and updated to reflect the changes and to ensure alignment with updated guidelines. Further advice will be provided once the resources are available and accessible, but you can see that some are already available if you do follow that link on the slide. Within the WACCPP, we also have a range of cervical screening resources tailored for the WA community, including brochures, posters and flip charts for stakeholders working with community members to promote cervical screening. We're currently reviewing these resources to promote self-collection as an option for everyone, and as well as introducing some new resources and communication strategies. So to receive updates on these, please email the WACCPP to join our Cervical Insight newsletter. You'll also be receiving the NCSP's toolkit for engaging under-screened and never-screened women, which outlines a number of barriers and enablers in certain groups that we'll discuss shortly as part of our panel discussion. So if there are further inquiries, contact the email address you can see on your screen to ask about the NCSP policy and guidelines and to ask about national resources. You can contact us at the WACCPP for all other inquiries, including those that relate to WA resources, health professional education, promoting cervical screening in the community and cervical screening participation in your region. And you can contact the NCSR, which is the National Cancer Screening Register, to request a patient's cervical screening history and find out when they are next due, and their details are just on this next screen. Lastly, these are our contact details at the WACCPP and, as I mentioned, the NCSR as well. Thanks very much, and I'll probably be taking questions as part of the later panel discussion, but I'll hand back to Megan now.
Thank you, Alana. That was, Alana, that was a great overview of the current state of play in both nationally and here in WA. And it's really good to hear that update about what the specifics of that policy change around self-collection and who's now eligible, but also that it's still there's still a need to engage with a healthcare provider for what that looks like and how that works, which is, I think, a really important part to that policy change. So that was really great. And as Alana said, it'd be great if you could all hold your questions until the end, and we'll do them all in one big go after we hear all of our speakers, because they might just answer some of the questions you have. And we will, like Alana said, be sending out both her slides, the toolkit she spoke to, our next speaker, Amanda's slides, and a resource list at the end. So there'll be plenty for you to look through and peruse over the coming weeks, right in time for Women's Health Week in a couple of weeks. So our next speaker today is Amanda O'Donovan, whose camera's just popped on, and I can see her, well, on my screen under me currently. Amanda is a clinical psychologist specialising in sexual and reproductive health. She has worked in a variety of settings, including the NHS in the UK, academia, women's health and sexual assault services, and was head of psychology in HIV and sexual health at Barts and the London Hospital. Her work incorporates mindfulness, compassion, systemic approaches, and community psychology. She is co-author of Sex and Sexuality, a manual for therapists and trainers, and co-founder of the My Body Back specialist cervical screening clinic in the UK for women who have experienced sexual violence, which is what Amanda will be giving us a bit of a lowdown on today. Amanda is currently Manager of Counselling at SHQ, Sexual Health Quarters, our family planning service here in WA. So over to you, Amanda.
And unmute is always helpful. Morning, everyone. Lovely to be here with you and to be thinking about these issues together. Hopefully I can make the technology work. So I wanted to again acknowledge that we're on Wajak Noongar Budja and to pay my respects to elders past, present and emerging. It's, I guess, in terms of my connection to this area, I've worked in, as Megan was saying, in sexual and reproductive health for, over 20 years. And I guess also just recently in a personal context, I'm a recent cancer survivor. So I guess the issue of screening and cancer prevention is even more close to home for me now. I guess in terms of why Get Papped, people might be aware of it. I just thought I'd give a plug to it. It's a really lovely kind of stigma reducing website, t-shirt, merch place, but they also do a directory of services that are recommended by people as being welcoming and inclusive, where you can have cervical screening. So it's just a really nice kind of community resource as well. The other thing I just wanted to mention in terms of language, I will talk about female sexual well-being and perhaps women receiving cervical screens, but also in that I acknowledge that obviously not everyone who has a cervix identifies as women or female, and some of these are, I guess, reflect the kind of language that was in use when these services were established. So some of you may recognise the building. It was in Sherlock. And this is where I worked for a number of years in a sexual health service, but also in a very well-established HIV service. And I think what was really striking about that was just how broad and holistic the multidisciplinary team was in HIV and also in the chronic fatigue ME service in which I worked. And it was very linked with community and advocacy. We had a lot of input from Positive East, and we did co-delivered services, which is a local East London HIV charity. And sexual health services were quite biomedical, very much a test and treat model. And over the time that I was there, we really sought to expand that model of care and set up a sexual wellbeing service. There was one, a male erectile dysfunction service, again, very reductive. And we set up a female sexual wellbeing service, myself and consultant Jill Zellen, where we worked together and saw patients together using mindfulness and other kind of holistic approaches to help people kind of become aware of and better manage sexual pain conditions like vaginismus, vulvodynia. So that was kind of my clinical background. And why isn't that slide going down? There we go. We also, as a sexual health service, obviously conducted cervical screens. And did colposcopy. And obviously we're aware that cervical cancer is a very preventable cancer. And again, as someone who's had cancer treatments, if you want to prevent if you are able to prevent cancer, you really want to do that. So I think really thinking about how we promote this as a public health intervention is something that's important as part of regular self-care is really key. And as Alana said, there's a sobering statistic on the number of percentage of people who are underscreened in the state. And when we know that that really, does put you at risk of developing, it's an unlikely outcome, but it's a preventable outcome in terms of not participating in screening programs. So Nicole Cree et al. Did a lovely review. We know that there's a lot of barriers to screening. We know that there are particular vulnerable groups where these factors are more salient, and Alana obviously mentioned those in terms of people with a disability, people from lower socioeconomic groups who might not have access to good health information and literacy, and also people with cultural barriers, like people from an ethnic minority where there are linguistic barriers, cultural barriers around shame, particularly when we think about now the idea of screening for HPV, and that might carry with it other stigma. So I guess really being thoughtful about that in the work that we do. And clearly, if intimate genital examinations are particularly problematic or triggering because of a history of sexual abuse or sexual trauma, we know that those groups are also underscreened. And I guess the demographics around that are very similar in the UK and in Australia, with obviously in Australia the addition of Aboriginal and Torres Strait Islander people also being underrepresented in screening programs. So I had the good fortune to work with the very lovely Louise Cadman, who is a nurse researcher and actually was instrumental in the widespread use of HPV testing in cervical screening and the adoption of the HPV screening program in the UK. And she did a lot of research, starting to a really early research looking at really understanding for women who had experienced sexual abuse and sexual trauma, what were the barriers around shame, anxiety, the triggering aspect, feeling exposed, relationship to help and trusting in health practitioners. And very sadly, Louise passed away a couple of years ago from melanoma, which, given she spent her whole life promoting cancer screening, was also quite a tragedy, but she did amazing work. And she was also a bit of a matchmaker. So she was in touch with Pavan Amara, who's an activist and very open about her own experience as a survivor of rape and sexual assault. And she set up a website where women could share their experiences and think about the relationship to their body, relationship to healthcare, and really think about how you get your body back after sexual assault. So here we are with me without a fringe and with, very good, very, very aware of my posture, I think I was in that photo. And that's where we set up the My Body Back clinic. So we worked with Jill Zellen, the medical consultant, and Louise, who ran the screening, did the actual screens, to set up a specialist dedicated clinic that was held in a different part of the building to allow women to come and have a very different experience of a clinical encounter around cervical screening. So what did that look like? How did we make it look different? Well, we had longer appointments, so they were doubled in time. There was a warm and welcoming environment. We had little ikebana vases with smears and speculums. There was flowers, there was cookies, tea and coffee. We had volunteers who would do the bookings and also do the meet and greet, who are also activist survivors in this space. We had experienced clinical psychologists. Initially, Pav and myself set up the clinic. There's a lot of French toast-based discussions at my kitchen table in the early days. And obviously the team expanded over time. And we also had very experienced medical and nursing staff who were very skilled in conducting cervical screening, but also in anticipating people's anxieties, very aware of the shame and stigma, and really aware of people traveling at their own pace. So of the 50, when we did an audit of the 50 initial attenders, 45 had a screen on their first appointment. another 3 had a screen on their second appointment, 2 declined to have screening, and 1 actually had a very recent sexual assault and wasn't appropriate for the service. So we're really thinking about meeting clients where they are at in that service. We used a mindfulness approach. So that was really helping women name what was happening for them in the moment as the screen was happening. And that really connected people to their bodies, created a sense of empowerment. We didn't get them to colour in underpants, but mindfulness is everywhere in lots of different formats now. But I think this is a really useful, I guess, component of the trauma-informed approach that we used. So this kind of talks you through the process. I won't go through it in too much detail, but you can see how there was a real mix of clinical staff and volunteer advocates involved in it. And that was really trying to de-clinicize the experience and have it feel very welcoming, very normal. Obviously, I'm happy to go through this in more detail after today. So we found that actually what we had done was created a trauma-informed service. Probably we predated the literature on trauma-informed care, but I think because it was such a joined-up model, it was co-created with advocacy, co-created with victim survivors, a very engaged, open, thoughtful, and we were very innovative in what we did. We also did workshops in a local sex shop called Shush, where we had, again, food featured heavily, morning tea, croissants and coffee, and we talked about sexual well-being post-sexual assault. So we really were able to be very innovative, and and all kudos to the hospital management who really supported this engagement and approach and helped us to really be thoughtful about delivering services in a way that met clients' needs. And I think, really thinking about, is a client hard to engage, or is it just that our service is not the kind of service that they want to engage with, and really thinking about, meeting clients where they're at. So currently I work at Sexual Health Quarters. We're on the Get PAPT endorsed practitioner lists, which is lovely. And obviously, as a broader sexual health clinic and counselling service, we see that people attending for cervical screen testing is also an opportunity to engage them in other kinds of preventative health behaviours, mental health interventions, and really think about broader sexual and relationship wellbeing, which is a really lovely model to be able to kind of engage in. We've also got a specialist service for people with disability. You may know it as the People First program, although that branding, I think, it's been retired actually while I've been off work. And we offer counselling, education and training. We also do, it's, I guess, in some ways a version of My Body Back, in that we do shared sessions with people with disability to attend the clinic, and we'll do advice and information sessions with them before they attend clinic. And again, there's no expectation that people complete a screen. They might just attend and have some information about screening, look at a swab, and that might be the intervention, and that's all they're at. That's where they're at the time. We also have an open evening coming up next Wednesday, quick plug, looking at supporting people to understand the role of cervical screening, and also the role, as Alana was elucidating, of the new self-test option, and help people understand that actually self-collection means collecting yourself but supported by a clinician. And there's also some really lovely resources around that Alana talked about, developed by WACCP and our colleagues at SECA, looking at supporting people with a disability in cervical screening. So we'll include the links to those in the slides today. What's lovely about self-collection, again, is it increases choice, and we know that's really important in trauma-informed care, and also to reassure clients that both options are accurate and safe, and also to help them understand why self-collection isn't take it home and do it yourself, although there's some new research in the UK looking at follow-up for people that don't engage in screening, and actually sending people a swab to their home address has a better uptake and return rate than a reminder letter. So that might be an evolution of the self-collection program later down the track, who knows. As Alana was saying, Australia hopes to be the first nation to eliminate cervical cancer, which is a huge achievement. It's the 4th most common cancer in women globally, with 900 cases in Australia in the year. So that's a huge target, I guess, both nationally, but also globally. And we really want to think about not leaving people behind on this journey towards reduction of cervical screening. And we're really lucky. Megan's done a great job in curating the webinar today. We have, some great speakers that, that really are across all of these underscreened or never screened groups, to really think about what we can be doing better, what we can be doing next to increase screening, and also very aware globally of it not just being something that becomes an issue. I think 85% of cases are in developing nations, and really taking the world along with us in the journey towards access and equity. That's me. Thank you very much for your time and attention. I'd love to continue the conversation with you later on.
Thank you, Amanda. That was really great to hear about a program with those really practical tips around trauma-informed care and what that looks like and can look like. Particularly, like you said, that might have predated some of the literature we now have, but how that collaboration really brought together a service that met the needs of a specific group of the community. And I will declare, I actually worked in Glasgow for a while and was quite heavily engaged with the My Body Back project in Glasgow as well. So, and we saw the benefit that it had up in Scotland. So it was a really great program. If anyone has any questions for Amanda or Alana after hers, please feel free to start adding them in the chat, and we will address them after our next panel discussion. But if something's on your mind right now, you're like, oh, I'm really thinking about, Amanda's got me thinking, Alana's got me thinking, start typing them in. And I have our wonderful 2 Masters of Public Health Prac students with me across the other side. You can't quite see them, but they'll start collating those so we can answer them right after our next panel discussion. So thank you, Amanda. Now we come to our next privilege with some even more great speakers. We've had a morning of great speakers already, and so it continues. So next we have a panel discussion with a whole range of representatives from different organisations representing those priority populations that both Alana and Amanda have spoken to. I'll introduce them one by one, and as we can make this very dramatic, and as I introduce you, please feel free to put your camera on and unmute yourself and give us a wave, panellists. So I'll start with Fiona McMullen. Fiona is the Coordinator of Education and Training at the Sexual Assault Resource Centre in Perth. She holds degrees in social work and psychology and postgraduate qualifications in adult education and human resource development. For the past 15 years, Fiona has worked in the area of sexual trauma and is an advocate of trauma-informed practice. Most recently, she has developed a collection of resources for survivors of sexual trauma, which are currently available on the SARC website. And again, we'll have links to all of these coming to you later this afternoon.
Hi, everyone. Thanks for having me.
Thanks, Fiona. Our next panellist is Rachel Pearce. Rachel is the Health Services Manager at Isha Multicultural Women's Health Service. She has over 10 years' experience working with people from culturally and linguistically diverse backgrounds, and has worked for Isha for the last 5 years. She oversees a range of health programs and represents Isha on a number of advisory groups to ensure the needs of women from migrant and refugee backgrounds are considered in the design of service provision. Isha provides information, advice and support for women from culturally diverse backgrounds, and Rachel manages all the health-related programs, including a women's health clinic, antenatal services, and health promotion. Isha carries out over 100 cervical screening tests a year and recently received a grant from the WACCPP to provide information workshops to address the barriers to cervical screening experienced by women from culturally diverse backgrounds. Welcome, Rachel.
Hello, thank you.
No worries. Our next panellist is Sarah Collins. Sarah Collins is a project officer and training facilitator at Living Proud LGBTIQ+ Community Services, and has a volunteer management and training background in sexual health aged care, LGBTIQ+, and volunteer support services. Sarah has been active in the Australian LGBTIQ+ community for 20 years as a paid worker, board member and volunteer, including working at the AIDS councils in WA and Victoria, and has previously served on the management committee of Pride WA, the diversity reference group at Rainbow Health Victoria, and the steering committee of Rainbow Futures WA. Thank you for joining us, Sarah.
Thank you.
Our next panellist is Dr. Rachel Skoss. Rachel is a Senior Research Fellow at the Institute for Health Research at the University of Notre Dame, Australia. Her research in health services focuses on how services can better meet the needs of people with disability and improving health literacy of caregivers and consumers. She brings lived experience via parenting a teen with an intellectual disability and has had various leadership roles in the disability and health sectors. Welcome, Rachel.
Thanks for the chance to talk to you.
Yeah, it's exciting. And our last panellist, Katiska Davis. Katiska is a proud Noongar woman working as the Youth Sexual Health and Bloodborne Virus Program Officer at the Aboriginal Health Council of WA. Katiska's role involves delivering sexual health education to young Aboriginal people through face-to-face deliveries via social media platforms and providing support to staff working in Aboriginal community-controlled health services. Thanks for joining us, Katiska.
Thank you.
Thank you. So that is our panellists today. And hearing that, I'm sure you can agree with me, we're very privileged to have such a wonderful collection of panellists participating today. So I will be asking the panellists a couple of key questions to hear their perspective on the impact that self-collection might have, but also what else do we need in both community and clinical settings to help increase screening uptake for our different priority populations. So we'll open the floor with what barriers are currently faced by the populations you work with that could be mitigated by the option to self-collect. So on my screen, I can see Katiska right front and center. Are you happy to lead us in that question?
Yeah, sure. So I guess I would have to say for Aboriginal women or people with cervical, it would definitely be the shame factor when it comes to testing. So I think, you know, with the self-collection, it would completely, I guess, get rid of that, like the fact that they can do it themselves. And I think that we would see a lot more Aboriginal women open to testing now, and even just having a yarn about it as well. Yeah.
Do you think the self-collection makes that having a yarn about it easier as well? That the fact there's another option, will that make conversations a little bit easier?
Yeah, absolutely. I was actually having a yarn about it with one of my friends recently, because she mentioned that in the town where she lives that there was no female doctors. So a lot of Indigenous women out there, they didn't actually want to go to the male doctor. So none of them were getting screening at all, and they weren't coming first for it. So I think now with self-collection, hopefully, because I mentioned that to her, a lot of them would opt for that now that they have that choice. I guess the only barrier there would be still having like a male clinician to talk about it with, and that might be a bit shame. So I think if, you know, we have women in those roles to bring it up, it might help the discussion.
Great, thank you. That's really insightful. Sarah, you're next on my screen. What about you in terms of the LGBTIQ+ community? What barriers do you think self-collection might help address?
I think some of the barriers, listening to the previous presentation, probably there are still, even with self-collection, there's still some barriers which, if there was the option to collect at home, would be mitigated even further. Certainly we know within LGBTIQ+ communities there are increased risk factors. We're now seeing a bit more evidence that our communities have higher rates of cervical cancer, yet lower screening rates. A lot of those often linked to the practitioner experience. So practitioners being unaware of the clinical needs of our communities, maybe missing opportunities for talking about prevention and screening. There's always that sort of fear of how you're going to be received by a clinic, of how people are going to be treated. There is still some sort of, experiences of prejudice, harassment, and I guess looking at the whole of the patient journey in that, not just the face-to-face with a particular practitioner. Again, as has been mentioned, scarcity of regional practitioners. So we know a lot of LGBTIQ+ people who will travel to Perth for screening. So if we can eliminate that need to sort of travel would be good. Self-collection generally might be more comfortable physically and emotionally, particularly for trans and gender diverse people who, may not be having those conversations with their practitioner. And certainly there's some studies showing that screening is actually more common in women who've disclosed their sexuality to their clinician. So I think it's kind of, while there are some things can be mitigated by self-collection, there's a lot more that can and should be done, particularly since if, self-collection still is going to have to be some engagement with the practitioner. So there are some mitigating things there, I think, but also a few other things that need to be looked at.
Great, and we'll come to those in the next couple of questions. So I'll stop you there to hear all of those, what we can do momentarily. Fiona, I can see you next. So what about from your perspective from SAR, what might self-collection mean?
Well, for our clients with a history of either child sexual abuse or sexual assault as an adult, it can make a huge difference. We know that a lot of our clients avoid cervical screening, or if they do go to a cervical screening appointment and it's not trauma-informed in its approach, they can be re-traumatised. Some of the reasons we know that our clients avoid are things like being alone in a room with a practitioner, a focus on the body, often the same parts of the body that were involved in the original sexual trauma, removing clothing, having an object inserted in the vagina. Those sorts of things often resemble the original trauma experience, so they can be very triggering for the clients. And I guess the main difference in the self-collection is that it allows control. So during sexual assault, sexual abuse, we know control is taken away from the victim, whereas this self-collection will provide the survivor with the control and result in less re-traumatisation, and probably a lot of our clients not avoiding going to have their cervical screening test because now they have a choice and some self-control over the process.
So very much echoing some of what Amanda said around that choice and control, but it sounds like from what you've said, Fiona, that some of those other barriers will still exist, much like Sarah said, like being alone with a clinician, and we can come to what that might look like, other strategies to employ. So while this is a really great step forward, there's still some gaps that we can address. Would that be?
Yes, definitely. And as previously mentioned, if in future the self-collection can take place at home, that would be even a greater step forward. And we know, for example, that survivors differ in their ability to cope from day to day. So if they were able to take their cervical collection at home, they could choose a time in which they felt comfortable and strong, and that gives them even more flexibility and control over that procedure.
Great, thank you, Fiona. Now, I've unfortunately left myself with the two Rachels at the end, which was a very poor facilitation on my end. Rachel Pearce, you're next on my list, and I won't do this with the next question. What about from the perspective at Ishar and your organisation's experience with some of the cervical screening programs you've run? What role do you think self-collection might have?
Okay, so with migrant and refugee women that come to our service, there's a few barriers, and some of which will certainly be addressed by self-collection. Our biggest barrier, though, is that that people from countries where they've maybe lived in a refugee camp for a long time, or a low socioeconomic country, less developed, is that they just don't understand preventative health. Why would you go to a doctor if you're not sick? Why am I undergoing a test? I don't feel unwell. So that's our biggest barrier. But the other big barrier is that our women are very modest and they don't like people looking at their private parts, and particularly men. We also, a lot of our women, or it's not uncommon for our clients to have undergone female genital mutilation or cutting, FGM. And unfortunately, doctors in Australia haven't always reacted well to that when they've been maybe for an antenatal appointment or something like that. And that's made the woman feel very embarrassed, and that certainly would be a barrier to them coming. And also the other barrier is the confusion between cervical screening and STI checks, that women don't really understand that cervical screening has nothing to do with multiple partners. It's, you know, just if you only had one partner, you can still get cervical cancer. So I guess the cervical screening, the self-collection, the real advantage is that modesty, and for the women that have undergone FGM, that they don't have to show their vagina to people they don't feel comfortable doing so. And we've just been running some health promotion work down in Katanning, and there's only male doctors down there. So a lot of the women that we were talking to down there were very keen on the self-collection. But what we have found at Isha is that whilst the women might come in thinking they want self-collection, once they meet the doctor and chat to the doctor, they actually opt for her to do it. So it helps them to come in and feel comfortable, but when the choice comes to it, they actually say, well, no, actually I'd rather have the doctor doing it because she'll do it properly, and things like that. So yeah, so that's just our experience at Isha.
It definitely sounds like, well, again, and that's, I think we're picking up a theme here. It's a great option and increasing choice and control and addressing some of the barriers. It's not all that we require, but also that really interesting take there, Rachel, that once that communication has happened with a client in the room and they're comfortable, that actually might change their decision and what they want once they're in there in quite a surprising or unexpected way, when they have attended thinking self-collection is what's brought them in the first place.
Yes, I mean, we have a lot of women that phone up and say, do you offer self-collection? And we say yes, and they come in, but we've actually only done self-collection once in the last few months. So yeah, it's not something they actually do in practice.
Interesting.
Yeah.
Very. And Rachel Scoss, what about from your perspective, which is slightly different, what can you see as the barrier reducing of self-collection?
If I can maybe first say that when we talk about disability, it's a very large term. There's lots of different types of disability. So if it's all right, I'm just going to focus on intellectual disability or significant cognitive impairment. And I think one of the barriers is people are often not offered the opportunity because there's assumptions being made that they're not sexually active, or it's too difficult to find to get consent for the procedure. So I think that's one of those barriers where which self-collection almost might provide more recognition, because it is a form of consent that if a person's wanting to do it themselves. I think there are a lot of physical communication and sensory issues which self-collection might help mitigate. And so it's able to be performed more sensitively in a safe environment. There is a barrier that approximately 20% of people with intellectual disability live in supported accommodation. And so there's that opportunity to really engage with those organisations to make sure this is something that's in people's care plans, that they're at least offered, and be promoted in annual health checks and things like that, just as a broader part of a push for preventative care. But it also means that oftentimes people are, another barrier is that people may be dependent on a caregiver, whether that's a paid support worker or a carer. And so one of the challenges, I think, is to make sure that there is the upskilling of the caregiver to support the process of self-collection, whether the individual's actually collecting it herself or whether or not it's in essence done by a support worker, that would be very challenging. So it's one of those things I think that might need to be addressed further. But yes, I think the other thing, the other challenge is, time, that the process of meeting, as Amanda said, meeting people where they're at and actually having enough time to do all of that preparation work in making sure that it happens in a safe manner and that it's not creating trauma. I think that's, another potential for self-collection to be a real bonus.
Great. And I might then stay with you, Rachel, because it's kind of, you've headed in that direction, which is our next question. What strategies can actually be implemented in the healthcare setting to encourage screening in the populations you all work with and are representing here today? You've started touching on that around time and explanation. In a practical sense, what might that look like?
Well, I think for people living in supported accommodation, they would all have care plans. And so this is something that, I think preventative care as a whole needs to be promoted more generally, but there needs to be a lot of preparation work with disability sector organisations so that they realise this is important. And so that there is all of the things that need to be put in place for someone to actually have the self-collection, in terms of making appointments, getting a person to where they need to be and all that sort of stuff. There's a lot of logistical issues that someone has to often organise on a person's behalf. So that's, something that needs to be taken into consideration. Always asking about whether there's some sensory conditions beforehand to make sure we can support the person. It could be that there's a better time of day to attend, reducing waiting times, because that can ramp up anxiety in busy, noisy and potentially chaotic environments. Ensuring that there's a safe and very private place and for the test to be performed, and also have someone trusted supporting that, whether that's a nurse practitioner or a GP or the like. I think there's a need for resources specifically targeting people who have low literacy. So, video examples that are step-by-step explanation of the process, but also why it's important. Flip charts and picture-based resources are also good. And questions that are framed in a very non-shameful way. It's also important to recognise that a vast majority of these people may not have really received a health education in high school or primary school. And so, it's meeting them where they're at and then bringing them along in terms of their own understanding of the process and supporting them to make decisions at each step of the way. I think it's also important to make sure that the follow-up is organised at the time and not left to chance, so that there's continuity of care for them. So that's my list of what I'd like to see happen.
No, that's really great, Rachel, because they're very practical suggestions, which I think is a really actionable thing when we hear these. While it might not feel that they're always easy to implement in practice, they are very practical in their nature around what those suggestions were in terms of how do we make healthcare settings more accessible and more encouraging to people with disabilities to access screening. Fiona,
can I just step back and say one more thing, is that it's really critical that they're first invited to participate. Oftentimes, because of the assumptions that are made, they're often not invited to participate.
And you're speaking to assumptions around non-sexual being not needing screening because they're assumed to be non-sexually engaged or not have sexual activity, therefore not be at risk. Yeah, really important part. And Fiona, I was just going to throw to you next, if that's okay, because some of what Rachel was talking to echoed what you were mentioning before around time and comfort and safety for trauma-informed practice. Would you like to, is there anything else that could be implemented in the healthcare setting? to encourage screening?
I think one of the most important things is to ensure that all practitioners and services are trauma informed, and that means a lot of those points that Amanda covered in her presentation, and it might, for example, include screening for trauma, whether that's verbal or written screening, but that in itself needs to be done in a trauma-informed way, and it doesn't necessarily mean finding out what sort of trauma was experienced. Just acknowledging that there is some form of trauma in a patient or client's history, and that what they're requiring is some extra sensitive approaches to their healthcare, and using resources that are available. For example, at SARC, we've developed a sensitive practice request form that's available on our website for download, and we've had a lot of positive feedback about that form. So it's a form in which people who've experienced trauma, any form of trauma, can fill in the form and take it to their healthcare provider. So a lot of trauma survivors find it difficult to verbally articulate their needs, and the form allows them to express their needs in advance, take it to their appointment and give it to the healthcare provider. It just gives the provider an understanding of how stressful and overwhelming the appointment can be, and what the provider can do to alleviate that stress and to help them get their healthcare needs met without being re-traumatised. So I think often trauma-informed approaches are not about what's done, but about how they're done. So they're done in a more respectful, sensitive manner.
And Fiona, that sounds like another tool, that form, to do what both Rachel and Amanda spoke to, of meeting someone where they're at. And that's another tool to be able to help the clinician do that, to have that before someone steps in, where it's already a very highly stressful, anxiety potentially inducing, re-traumatizing environment. So is it okay if we share that link post in the email that goes out as well? Because I think that's a really good thing for people to have. Now, Katiska, I was going to throw to you next, because Rachel mentioned non-shaming, questioning and having discussions that aren't shaming, and that's something you picked up in the first response. What do you see as being really important strategies in a healthcare setting to encourage the uptake of cervical screening?
I think with thinking about Aboriginal medical services, maybe introducing the young before it even comes time to test. So then, you're making people aware of, what's involved, and that, eventually, when they get 25 years old, that it's recommended for them to be testing, because I think people just aren't aware. From what I've experienced, anyway, if I wasn't, in this field, then I don't think I would know, because I actually probably haven't had the discussion, and it's not really something that, I've grown up with a lot of men in my family, so maybe that's why I've not had the discussion, but that with women yarn about with each other that we need to be getting this done, and that's maybe because we're not getting this done. So yeah, I think it's from the health promotion side, I know I try to bring it up when I talk about testing in general. So yeah, just introducing the comfortable space to talk about it, and answering people's questions if they have any. Yeah.
And it sounds like you're describing that could happen both through a clinical healthcare setting, like an AMS, before someone reaches screening age, but also in those community settings as well, and that it doesn't have to always be in the healthcare setting to have those yarns and to start people thinking about what might happen when you turn 25, what is screening and why that's important.
Yeah, absolutely. Because I think, if they think that, that's just associated with that AMS. It's like, oh, I don't want to go there, I don't want to do that. Yeah.
That it's that lead up work that's not only in that appointment at the time, it's all those conversations before. And Rachel Pearce, I can see you nodding quite enthusiastically along with that. Is that something you would also describe, and from what you said, for many of your clients?
Yeah, absolutely. Sorry, cut out a little bit there, but yes, I mean, I think there's lots of things that people have touched on that certainly would make our clients feel a lot more comfortable in a healthcare setting, and definitely that sort of community engagement early on is really important. The main thing for us would be female doctors to be available, and I think that's across the board for everybody, and the use of interpreters. So sometimes doctors are not willing to use an interpreter and they ask you to bring a family member. That's not appropriate for something like an intimate examination, like a cervical screen. We offer our clients a choice of interpreters. So some people would rather have an on-site interpreter, so somebody in the room because it's easier to understand them, but also some people would rather have a telephone interpreter because then there's less people in the room when for the procedure. So definitely ask them what they would prefer. It would be great if there was a GP or someone from their own culture that could explain the procedure, who could maybe know so it's a cultural lens, so they know what's norm in their country and sort of explain it in words that they might understand. We always book longer appointments, so at least a 20-minute appointment, using lots of visual aids, lots of pictures to show people what's going to happen. We use a model, we have a speculum they can have a look at, using very simple English terms, not using medical terms. We have a lot of resources, pamphlets that people can read in their own language, but that doesn't work for everybody because not all our clients can read even in their own language. A lot of our clients haven't been to school. So there's also videos available that people can access. A lot of these points people have touched on before. So really making sure you build the patient's trust. So taking time in that appointment, maybe not bringing it up at the first appointment. It depends on the client. A lot of the women, when they first come as a refugee into Australia, you actually have to go through a lot of tests and a lot of vaccinations and a lot of medical procedures. And because cervical screening is optional, if you bring it up too early, people may say no, just because they want some control. So they maybe haven't had any choice with some of the other tests they've had to undergo. And this is something that they can actually say, oh, actually, no, I don't want that one. So it might, so sometimes it's better not to bring it up at the first appointment, and to let the client come to the service a few times and then bring it up later on. Making sure that the women are really know that the results will be private and confidential, that no one else will know about them. They won't be sent home to the husband or anybody else, that this is just for your use. Explaining that it might be a bit uncomfortable and that I can stop if it hurts, that sort of thing. So just really reassuring. And then I just wanted to touch a little bit on the FGM, the fetal genital mutilation. And it's just so important that doctors don't trigger the women. I think other people were talking about non-shameful way and asking questions if you need to, but it's really important that those questions are not racist and not profiling when people come in. So we ask all women, do you have any concerns about your genital area? Do you have any relevant medical history that you think that you would like to talk to me about? Have you had any surgery or procedures on your vagina in the past? So those sort of questions, and we ask all our women, we don't just we don't racially profile them before asking those sort of questions. And often women will say no when they have had FGM because they don't believe it is anything different, anything that they need to talk about or highlight to us. So again, it's making sure that the doctor reacts well to that and doesn't draw attention to it, just carries on with the procedure, doesn't really comment on that. So certainly in a clinical environment, those are just some of the strategies that we use to make the women feel more comfortable and more happy to have their cervical screening done.
Yeah, so Rachel, it sounds like, well, again, like you said, picking up some of the things others had mentioned, but really specific clinician upskilling around FGC, FGM in particular, to ensure that that response is appropriate and as it should be. And that's, I think, a really, really great tip and a really good strategy that's really important when we think about cervical screening and what that looks like for our different priority populations and addressing some of those barriers. And rounding out thinking about healthcare settings, what are your thoughts, Sarah? Like, I think we've picked up some of from your response to the first question as well around clinician training and expectations. Is that something you see as being important as well in this space?
Very much so. And the kind of an expanded kind of idea of what inclusive practice is, because people tend to think it's about, you know, pronouns and non-gendered language, which it is, but it's a lot more than that. So things like, how do you take an inclusive sexual history? You know, had the necessity to ask people about the preferred ways of referring to body parts, sexual behaviours, so that you're using the language that they use. For trans and gender diverse people, often there's assumptions around anatomy, or, you know, if someone is, if there's a trans man who, you know, has medical records that say this person is a man, then they're not going to be offered cervical screening. You know, so it's about working with bodies, you know, and kind of being able to, in your language and in your practice, kind of talk about that appropriately in ways that still respecting people's identities. I think also being aware about some of the misinformation that's out there. There's often some misinformation that women who don't have sex with men are not at risk and don't need cervical screening. And that can sometimes be reinforced by the health professional themselves to sort of say that, oh, maybe you don't need that test. We do anecdotally hear that. Probably one of the big ones is, as I said before, you know, the screening rates are higher amongst women who are out about their sexuality to their practitioner, yet we still hear that within a clinical setting that the practitioner won't ask about sexuality or gender diversity. They will wait for a patient to disclose. But then if you talk to the patients are going, no, I'm waiting for someone to ask me, and then I'll disclose. So I think that's one of the real disconnects that's going on.
And it sounds like that might echo, in a way, what Fiona, that form you were speaking to kind of addresses a similar issue, but in a different way, that sharing of information between a patient and their healthcare provider, and who's waiting for who to disclose something, and having strategies to ensure that that communication happens without everyone kind of sitting there waiting for the other person to raise it in the first place. Similarly, Rachel Scott's picking up, I think, for people with disabilities, similar kind of idea. How do we share that information and really communicate risk well, I think, is what we've spoken to a few times here about who requires screening and what that looks like for different cohorts. Sarah, I might stay with you, because while we move from the final question with 15 minutes to go, and we'd like to hear some questions for the audience, from the audience, if there's any. So if people do have questions, please start typing them in the chat so we can get to those, make sure we get time for those. But just to kind of round out our discussion here, we've talked about what might work in the healthcare settings and strategies to increase screening uptake. But what about in the community setting? We've touched on a little bit of that, and I think, Sarah, that's that misinformation. What strategies can we implement in the community setting to encourage cervical screening?
I think having some very specific targeted health promotion for particular communities. I went a few years ago to the Queer Film Festival in Melbourne, and for every film there was a promo which basically said everyone who has a cervix needs to get cervical screening, and it featured prominent queer people from within the Melbourne community, so it was people that people knew, and they had all the conversations about, this is not fun, this is uncomfortable, this is, you know, but you still need to do it. You know, so those very, very targeted messages are, you know, it's that thing where if it's something that's not very nice to do, you know, people are going to find reasons to not do it. There are lots of LGBTQ plus groups in the community that have sort of lists of providers that are, you know, anecdotally known to be kind of okay for our community. Quite a few of them, it's a bit like, you can go to this service, but make sure you talk to this particular practitioner. So we really need to kind of promote that there needs to be a service where you can see anyone within that service and you'll get a good service. You'll be, you know, inclusive service. There's been a bit of talk about sort of peer-driven and community-driven services. That would be the optimum. So if you can have sort of, you know, satellite clinics, pop-up clinics, especially in regional areas, with, you know, that's kind of organised by peers. Be absolutely fantastic if the practitioners were peers as well, but obviously that might not be possible. That sort of community controlled kind of healthcare setting is so important, and I certainly have personal experience of this. And I think in our community as well, intersectionality is a big thing. So, you know, the conversations that a practitioner might have about someone being LGBTIQ plus don't tend to happen if that person has a disability, or if that person is from a different cultural background. There's suddenly the assumption that they're not going to be part of LGBTIQ plus community. I've actually found this myself as someone with disability. The only time I remember being asked by a GP, when did you last have a pap test, was at an LGBTIQ plus specific GP practice. No other GP has asked me that, and I don't know for sure that's because I have disability, but you know, it's a possibility. So I think there's that awareness in all the areas we've talked about, but also that intersectionality, and that one doesn't cancel out the other.
Thank you for that insight and sharing your own experience, which I think just really echoes what we've heard already. And Rachel Scoss, I can see you nodding as well along with that. Can I throw to you next? What might community settings look like to increase screening?
I think Sarah's experience, I think, is fairly common, that particularly for people with disability, that it's about people reaching, the clinical folk tend to focus on the disability rather than any other needs, and it's often called diagnostic overshadowing, and it's quite prevalent. I think just having resources that are accessible and thinking about all of the people that are around in terms of supporting a person, that they also have to be targeted, have targeted preventative care information, because they are often the ones who are going to be facilitating it. I think there really needs to be advocacy for preventative care to be a priority, particularly in times when, you know, funding through NDIS is around individual support needs. The preventative care often doesn't get a look in, yet it does cost money to support someone to access services. So we need to think about how services can be delivered in an accessible way that's not going to have any cost barriers. Just thinking about how, you know, healthcare days could be promoted, where, you know, again, I think those pop-up clinics are a terrific idea, and also liaising with the various peak organisations that are working in the space, who often have deeper reach around specific groups. You know, that they are a really useful resource too, and are always wanting to be involved. And, you know, it comes back down to also having those inclusive healthcare settings, understanding and having the skills to both engage and communicate with people with diverse communication needs would be helpful. I think that's about it. Oh, and just, you know, again, time. It takes time to build trust. And so we need to think about the long game, about getting people back for subsequent meetings, and recognising where past trauma might influence their current level of engagement, and just really working with everybody to reduce those sorts of barriers as well.
Great, thank you, Rachel. And Fiona, on that kind of talking about past trauma and current impacts and your experience developing resources, I might ask for your input here now. What might it look like in community settings, do you think? What strategies can we implement?
Well, I think it's just important to spread the word for a start, and that's both amongst potential patients or clients, but workers as well, and not just in the health field. For example, counsellors who are working with people who've experienced trauma can open up those conversations about women taking care of their own health needs, etc. And I think once we are trauma informed as a service, it's really important to let the clients or the patients know that we have an understanding of trauma, and we're committed to working in partnership with you to get your healthcare needs met. And also that inclusive language that was just mentioned before. So we need to be mindful about how we market our services so we are inclusive and welcoming to all groups.
Great, I really like that. I think that's a great point around that if you're doing the work, it's okay to let people know that that's actually one of those signs to the community that this is somewhere that you are safe. And like you spoke to, Sarah, that it's not just one clinician in this building or in this organisation. This is actually a collective effort that we're all okay, we're all safe, we all understand, and we'll be trying our best to work, like you said, Fiona, in partnership with you for your healthcare and wellbeing. I think that's really
long term, ideally, if we could have trauma-informed systems, so as people move through the different services within the system and they're not re-traumatised, and they are met with clinicians and workers who understand trauma and its impacts and how to work with it, that would be the ideal.
I'm all for ideals. I'm all for thinking what we should aim for at the end. That's really great. And so I really appreciate that. And I think this is one of those steps on that journey that we've got 30 odd people here today thinking about, well, how do we do this? And we've got clinicians, we have community health workers, we have workers from a range of different settings. So hopefully some of this is really practical, like you said, in all of those spaces, then the role that we can all play. It's not only if you're a clinician that you can start these conversations, it's if you're working with any priority population. And Katiska, what about picking up what you were saying before, that starting the conversation quite early? Do you see that as, what's the role of kind of the community setting in your mind?
I guess it would probably be maybe something like Women's Health Days, for people to be able to come along and, you know, have a yarn, and, you know, then it's not the, I guess, pressure of, okay, I'm going to go in and I'm going to get a test today. Like, they can have a yarn about it first, but the option's there if they do want to get tested. Yeah. Sure.
So that, again, that kind of time, like you say, kind of casual engagement. If you're feeling up for it today, that there's the option there, but you don't have to. No pressure, might be at the second, third, fourth appointment, but that in building on those trusted relationships.
Yeah, absolutely.
Fantastic. And Rachel, what about yourself? Anything else to add, Rachel Pearce?
Yeah, so I think a lot of the things that, you know, have already been covered by other people, certainly that trauma-informed care for our women around the FGM is really important. Pop-up clinics for women in areas where there's maybe only male doctors, like in some of the regional areas. I guess for us, the way that we've increased cervical screening is really by concentrated health promotion programs. So delivering health promotion activities in the communities to community groups in their own language by someone that they know, so someone that they trust and know. And then as part of that is we can't always have a doctor on site, which would be lovely, as Katisha was saying, but at least the health promotion officer can actually make an appointment for the women. So particularly for the women that don't speak English, they can actually phone and make that appointment for them, make sure that there is going to be an interpreter. They can request a female doctor, see whether self-collection is available at that centre, and ask those questions that might be barriers to people. So that's we found is a really important thing to do. And then the other thing is having information in language about cervical screening, and maybe putting it on community Facebook groups, WhatsApp, Viber groups, those sort of things. Some of the communities have newsletter websites and things, so actually getting that information out to people via online platforms. And then I think this is also something that Katisha touched on, is actually educating high school students and university students, so that when you've got them at school and they actually will go home and talk to their parents, their mothers about it and say, come on, mum, you need to come and have this as well. So it's not just for them and sort of getting them to think about it earlier, but also for them maybe to discuss it with their parents and particularly with their mothers to bear in mind. And one thing I didn't say earlier is just making sure that there's bulk billing services. So I think most of us deal with clients who really can't afford health services. So yeah, making sure that people have access not only to a female doctor, but to a bulk billing service. So.
Thank you, Rachel, because I think that is a fantastic, like you said, that we've got and a great end point around bulk billing services, and the real practicalities of accessible services means something that's affordable at its bare bones. So with all of that other work, but we can't forget those kernels that really uphold accessibility in terms of healthcare as well. But it sounds like, and that's across the board for all of the groups we're talking about today and increasing screening, is that genuine community health promotion work talking to people where they're at in a way that talks to them, and doing that in a genuine way, and not kind of expecting information to be sought out that we think is the right information somebody needs, but actually working in collaboration and thinking really creatively, by the sound of it, about how we get that information out to people, whether that's using a WhatsApp or Viber group, talking to professionals that wouldn't maybe necessarily see themselves as having a role in cervical screening, or promos in front of films at festivals, talking advanced care plans and preventative health, or in schools and universities. It's a multifaceted approach to health promotion that it sounds like is the real key to getting increasing uptake for cervical screening. So I might ask Alana and Amanda to join us back on camera, and if there's any questions coming through, which we've got one, so I'll throw it to all of the panelists. What else is needed in terms of resources to support participation? We've talked a bit about here community engagement and tailored health promotion. Is there some resources you can think of that's like, yep, that'd be fantastic if we could have that made? I'll throw it open.
One thing that we've talked about, which would be fantastic, is similar to the breast screen buses that go around to regional areas. If we could have something like a cervical screening bus that could go to expos and events where we're talking about cervical screening, and then women could actually go and have their cervical screening done, and also could visit some of those remoter areas where there isn't maybe the female doctors, or there's not regular doctors there. So that would be fantastic.
I see a few nods. I feel like that might be people would like a CST bus. Alana, what do you think?
I knew that question was going to be directed at me. It's definitely something that we've talked about as a program. We're definitely aware of it. There are a few practicalities and logistics which are involved with it in terms of sort of continuation of care and things like that. But yeah, it's definitely something that's on our radar as a program.
Any other resources people think would be useful and practical?
Can I just extend that and say having an in-reach service for people who may have difficulties getting to a health service or even a bus, that would be helpful. And as far as resources, I think, you know, some of those really short, sharp, cartoon type explanations of what goes on are really helpful for people who have really poor literacy, and can be very engaging.
And you mean more video style, Rachel?
Yeah, little YouTube clips.
Fantastic. Amanda?
No, I was just about to say on the back of Rachel's comment, so any volunteers to make a cervical screening self-test TikTok? I'm the wrong generation, but, you know, looking at you, Katiska.
I think that's a great idea. Yeah, that would be so much fun.
Yeah.
Yeah, absolutely, with the swabs.
Yeah, woo! Swabs.
But I think it's also, there is so much stigma, and I think with this shift to HPV and the emphasis on HPV, you know, as Rachel was saying from Isha, you know, that idea about how do you really kind of position this as a public health and kind of destigmatize the idea that you're having an STI test, because that can be another barrier. But I think what's really lovely and I think really important is just all the passion, and I think having champions and people that are really committed in an area is super important. So I think we're really lucky to have you, Megan, leading in this space as well.
Thank you, Amanda. No, it's been an absolute pleasure to hear from all of our speakers and panelists today, because I think that was the real aim for today. And I know we've hit bang on 11:30 right now, but it really is these practical tips around what, both in a healthcare setting and the community setting, can we all be doing to increase the uptake of screening so that we can hit that goal of elimination by 2035. And that will take a concerted effort by all of us, and we all have a role to play. So I just wanted to thank everybody that spoke today and everybody that came along, because it really speaks to, like Amanda said, passion for this space and a real commitment to work with community and for community to improve outcomes. And I'd just like to add in that Heidi's added a comment in the chat that Victoria Self Collection have sent her some self-addressed envelopes. So have performed consultation with a client, but they can still screen in their own environment where they feel safe. So we've touched on it a few times, that idea of the goal of maybe down the line being at home self-collection. There might be that possibility in the future and what that might mean. As I've said a few times, we will send out a whole heap of resources that include some things we've spoken to today. And I'd just like to highlight, it'll also include a link to some videos created by, I can see the Headland Well Women's team here, that they created locally about addressing some of the barriers to screening. And also I can see Jordana here from SECA. SECA have a new resource as well that is both printed and available online. So there's some stuff continuing to come out that hopefully you may have seen, may not have seen, that hopefully addresses some of those things we've spoken to, and we'll all keep going on this path. And we'll also send out a feedback survey. So if you could please complete it, it would be an absolute joy. It won't take very long. It's not a huge ask, but it'll be included if you could click on the link. And if you have any questions following up today, please feel free to email me directly. The email will come from me later today, and it's great. I can pass it on to the relevant person or connect people in, because we've got a range of attendees today. And again, I'd just like to say my deepest appreciation and thanks to everybody who spoke today. It's been a really informative morning, and thank you all for coming.